The Recovery Kernel Substance-Specific Navigation Series. How to recover from GHB. Using the Recovery Kernel Framework. GHB, GBL1, for BD, sodium oxybate, Xyrem, liquid ecstasy, G, fantasy. Warning: harm reduction resource, not medical advice. Crisis, call 911 or text 988. GHB withdrawal can cause fatal seizures and psychosis. Do not stop abruptly without medical supervision if dosing every few hours. A note before you begin. GHB recovery may be the least documented and least supported recovery journey in this entire series. It is not because GHB use disorder is rare, it is because GHB exists in a strange cultural and clinical blind spot. It is simultaneously a Schedule I controlled substance, an FDA-approved medication, sodium oxybate/Xyrem, for narcolepsy, a harm reduction tool used by some to manage alcohol cravings, a Chemsex drug prevalent in LGBTQ+ nightlife cultures, and a molecule the human brain produces naturally in small amounts. Its users span a broader range of contexts than almost any other substance in this guide series: the person managing narcolepsy, the weekend club user who gradually found they needed it every few hours, the Chemsex participant whose recreational use became hourly dependence. What unites all of these stories is the biology. GHB acts primarily as a GABA-B agonist and also activates its own GHB-specific receptors, producing a GABA-dependent physical dependence that, when severe, is as medically dangerous as any substance known. The GABA2 high-risk variant that the compendium identifies as the hard-fail genotype for combining alcohol with GABAergic agents applies here with full force. GHB withdrawal at high frequency and doses is a medical emergency with a documented mortality risk. This guide covers the full spectrum, from recreational GHB users who have developed problematic patterns, to people dosing every 2 to 3 hours around the clock, to those prescribed sodium oxybate who need to reduce or discontinue. The biology is the same. The medical urgency varies with the frequency and dose. Read Section 0 first. Then continue. Section 0, Immediate Safety, read this first. Warning: GHB withdrawal at high-frequency use, every 2 to 4 hours, can cause seizures, delirium, and death within 2 to 6 hours of the last dose. This is not exaggeration. Do not stop abruptly. Who needs medical detox? The assessment. Classical: building the centurion, the line that determines whether you read on or call a doctor first. Answer these questions honestly before proceeding. If you answered no to all of the above, you dose once or twice daily, have not experienced physical withdrawal symptoms when missing a dose, and have a stable pattern, a careful monitored taper may be possible with medical guidance but without inpatient detox. Discuss with a physician before reducing. GHB overdose recognition and response. Warning: GHB overdose progression, sedation, unconsciousness, respiratory depression, death. The window is narrow. The dose that sedates and the dose that kills are close together. Unresponsive, cannot be roused by voice, sternal rub, or pain stimulus. Slow, shallow, or stopped breathing, the primary cause of GHB death. Blue or gray lips or fingernails, oxygen deprivation. Vomiting while unconscious, aspiration risk, roll to recovery position immediately. Seizure, a medical emergency at any stage. Warning: there is no reversal agent for GHB overdose. Naloxone does not work on GHB. Unlike opioid overdose, there is no pharmacological reversal for GHB overdose. Supportive care, airway management, oxygen monitoring, is the treatment. This is why calling 911 immediately is the only appropriate response to a suspected GHB overdose. Do not wait to see if the person wakes up. GHB overdose can progress from sedation to respiratory arrest in minutes. GHB plus alcohol combination, the compendium's hard-fail scenario for GABA2 high-risk individuals. Both substances are GABAergic. Their combined effect is not additive, it is synergistic and can produce respiratory depression and death at doses that would be non-fatal individually. This combination kills. Do not combine GHB plus any other depressant. GHB combined with benzodiazepines, opioids, ketamine, alcohol, or antihistamines dramatically increases overdose and death risk. No exceptions. The dose measurement problem, the most unique danger of GHB. Classical building the Centurion, GHB is sold as a liquid with no standardized concentration. GHB is typically sold as a clear, odorless liquid in unlabeled bottles with no concentration information. A teaspoon of one batch may contain 1 g. A teaspoon of another may contain 4 g. The difference between a recreational dose, 1, 2 g, and a dangerous dose, 3, 4 g, and a potentially lethal dose, 5 g+, may be invisible in the same volume of liquid. This measurement problem is the primary driver of accidental GHB overdose in recreational users. Tolerance, batch concentration variation, and the combination with alcohol create a lethal uncertainty that no other common substance matches in its unpredictability. If you are using GHB, use a precise oral syringe, 1 ml markings, for measurement. Never drink directly from the bottle. Never measure with spoons. If you are helping someone who uses GHB, know the signs of overdose above. Know that 911 is the only response to unconsciousness. Know that there is no reversal agent. GHB test kits, available through harm reduction organizations, can verify the presence of GHB but not concentration. Use them. Section 1. What GHB did to your brain. Classical building the Centurion, the molecule your brain already makes, used at a scale your brain cannot manage. GHB, gamma-hydroxybutyrate, is endogenous. Your brain produces it in small amounts as both a neurotransmitter and a metabolite of GABA. This biological familiarity is part of why GHB's effects feel qualitatively different from other substances. The brain recognizes this molecule. It has receptors specifically designed for it. Exogenous GHB at recreational and addictive doses operates through two primary mechanisms. The two receptor systems GHB disrupted. The half-life problem, why GHB dependence is uniquely dangerous. Classical building the Centurion, the brain recalibrates to whatever schedule you give it. GHB has a half-life of approximately 30 to 60 minutes for the active compound, plasma levels, with a duration of effect of 1.5 to 3 hours depending on dose. This is dramatically shorter than alcohol, hours, benzodiazepines, hours to days, or opioids, hours to days. The consequence, a person who uses GHB every 2 to 3 hours has trained their brain to expect a GABA-B agonist signal at 2 to 3 hour intervals. The GABA-B receptors have downregulated around this schedule. When a dose is missed, or when the person is asleep and cannot dose, the brain experiences acute withdrawal within 2 to 4 hours of the last dose. This creates the defining pattern of severe GHB dependence. The person must wake multiple times per night to dose. They cannot travel on planes. They cannot attend medical appointments, work shifts, or social events that would put them more than 2 to 3 hours from their supply. Their entire life has been organized around the dosing schedule. And the physical dependence has been building the entire time. This is not weakness. This is what GABA-B receptor biology does when it is chronically overstimulated on a short cycle schedule. The trap is pharmacological, not characterological. The GHB class, forms and precursors. Classical building the Centurion, GHB by any other name is the same biology. Who uses GHB and why? The contexts that shape recovery. Classical building the Centurion, context determines what was being managed and what recovery must address. GHB use disorder appears across genuinely different populations with different underlying drivers. Understanding which context describes your use determines which additional recovery elements beyond the core GABA reconstruction protocol are most important. Section 2, Your Genomic Blueprint. GHB recovery has a specific genomic profile that maps directly onto the compendium's GABA system genetics. The same variants that determine alcohol and benzodiazepine risk also determine GHB risk, with one additional consideration unique to GHB's role in chemsex and dopaminergic contexts. The DNA testing panel for GHB recovery. Section 3, the Detox Protocol. Warning: GHB detox is a medical emergency for anyone dosing more than 3 to 4 times daily. The seizure and psychosis risk in the first 12 to 72 hours is real, unpredictable, and can be fatal without medical management. 3.1 Why GHB withdrawal is uniquely dangerous. Classical building: the centurion, the shortest half-life, the fastest dependence, the most abrupt withdrawal. GHB withdrawal is medically distinct from alcohol and benzodiazepine withdrawal in several ways that make it particularly treacherous. Speed of onset: because GHB has a 30 to 60 minute plasma half-life, withdrawal begins within 2 to 6 hours of the last dose for dependent users, far faster than alcohol, 6 to 24 hours, or benzodiazepines, 12 to 48 hours. The window from last dose to seizure risk is extremely narrow. Unpredictability: the clinical severity of GHB withdrawal does not always correlate predictably with the reported use pattern. People who underreport their use, or whose street GHB had variable concentration, may present in more severe withdrawal than anticipated. Psychosis: GHB withdrawal produces a specific delirium and psychosis syndrome that can develop rapidly and is distinct from alcohol delirium tremens in character, featuring agitation, confusion, visual hallucinations, and extreme autonomic instability. This is not simply anxiety. It is a neurological emergency. Treatment complexity: unlike alcohol withdrawal, benzodiazepines, or opioid withdrawal, buprenorphine, there is no FDA-approved specific treatment for GHB withdrawal. Baclofen, a GABA-B agonist, is the most evidence-supported option and represents the most direct pharmacological match to GHB's primary mechanism. Benzodiazepines are used but are less pharmacologically specific and may require very high doses. 3.2 Medical detox options. Classical building: the centurion, the treatment landscape for the most underserved withdrawal in medicine. 3.3 The withdrawal timeline. 3.4 Post-acute withdrawal syndrome in GHB recovery. Warning: GHB pause can persist for 12 to 18 months and may be among the most protracted pause syndromes in addiction medicine. The anxiety is real. It is neurological. It will resolve. Pause in GHB recovery is characterized by episodic severe anxiety, sleep disruption, cognitive fog, cravings that appear suddenly and intensely, and emotional volatility that can appear weeks or months into recovery without warning. The GABA2 high-risk genotype is associated with more severe and prolonged pause. GHB pause is particularly challenging because the anxiety component is severe, often more severe than pause from other substances, and because the drug that would relieve it is the one the person is in recovery from. Managing this anxiety through non-pharmacological and supplement means requires the most robust implementation of the GABA restoration protocols in this guide. Pause, interrupt, return to Protocol 01, shelter. Execute 4-7-8 breathing immediately and repeatedly. Contact your medical support. Increase magnesium glycinate dose. Use L-theanine. If psychotic symptoms appear, hallucinations, severe confusion, at any point in the recovery period, this is a medical emergency, not a pause episode. Go to emergency services. Section 4, Biological Reconstruction. GHB recovery requires the reconstruction of 3 systems: the GABA-B receptor system, the primary target, the dopamine system, secondary, and the HPA axis, stress response normalization. The methylation foundation underlies all 3. This is architecturally similar to alcohol recovery but with specific additions for the GABA-B receptor subtype and the unique neurochemistry of GHB's own receptor system. Everything in this section, discuss with your physician before starting, especially given the potential for supplement drug interactions during any medication taper. Some supplements, lemon balm, valerian, high-dose taurine, can enhance sedation if combined with baclofen or benzodiazepines. 4.1 The Methylation Foundation. GHB, GBL, and 1,4-BD all place metabolic demands on the methylation system. The production and breakdown of GABA itself is B6 dependent. Addressing methylation deficits is the non-negotiable first layer. 4.2 GABA-B System Restoration. Classical building the centurion, supporting the system that was borrowed against, specifically. GABA-B receptor upregulation is a structural process that occurs through abstinence, time, and the neuroplasticity supported by BDNF and appropriate cofactors. Supplements support the conditions for this upregulation, they do not directly replace GHB's GABA-B activation. The recovery is biological and time-dependent. Warning: caution with supplement timing. If you are currently on a baclofen or benzodiazepine taper, discuss all supplements with your physician before adding them. GABA-supporting supplements can enhance sedation and respiratory depression when combined with these medications. Add supplements only once the taper is complete or under physician guidance. 4.3 Dopamine and serotonin reconstruction. Once the acute GABA/glutamate crisis has passed, the dopamine and serotonin systems that were secondarily disrupted by GHB become the primary targets for the long-term recovery phase. 4.4 Sleep reconstruction. Classical building the centurion, the system that controlled your sleep schedule must now rebuild its own. For dependent GHB users who were dosing nocturnally to prevent withdrawal during sleep, the most defining feature of severe GHB dependence, sleep reconstruction is both the most urgent and the most challenging aspect of recovery. The brain that was using GHB as a sleep induction tool has not practiced the natural sleep initiation process for months or years. The endogenous GABA-B activity that normally facilitates sleep onset has been chronically suppressed. The sleep architecture damage is profound: no natural deep sleep, no REM, no circadian entrainment, just GHB-induced unconsciousness on a 2 to 3 hour cycle. Melatonin, 0.5 to 1 mg sublingual, 30 to 60 minutes before target sleep time. Low dose is critical, high doses disrupt circadian rhythm rather than supporting it. Add tart cherry extract, 480 mg, for additional melatonin precursor support. Magnesium glycinate, 400 mg elemental 1 hour before bed, the single most important sleep supplement in GHB recovery for its GABA receptor stabilizing and glutamate reducing properties. Glycine, 3,5G, 30 minutes before bed, reduces core body temperature, the primary physiological sleep trigger. NMDA coagonist that supports the GABA-glutamate rebalancing needed for sleep architecture. L-theanine, 200 to 400 mg evening, alpha wave promotion without sedation. Reduces the anxious hyperarousal that prevents sleep onset in early GHB recovery. Phosphatidylserine, 100 to 200 mg evening, reduces evening cortisol that blocks sleep onset. Inositol, 4,8G evening, serotonin and GABA receptor modulation, supports the transition to sleep without sedating. Also execute Protocol 17, Sleep Architecture, from the main compendium in full. The GHB-specific edition, the expectation of waking in the night will be present for weeks or months. The brain was trained to wake every 2 to 3 hours. Do not interpret this as failure. Do not dose GHB when you wake. Use the 4-7-8 breath and return to sleep. The pattern will gradually extinguish with consistent practice. 4.5 Peptide Support Layer. The following peptides have mechanistic relevance to GABA system recovery, neuroinflammation, and the specific neurotoxic effects of GHB and its precursors. Physician discussion required. Section 5, The GHB Craving, Understanding and Interrupting. Classical building the centurion, GHB cravings have a physiological component unlike most other substances. GHB cravings in early recovery have a quality that distinguishes them from most other substances. They can be accompanied by genuine physical anxiety, not just psychological wanting but a body-level alarm signal that mirrors early withdrawal. The GABA-B system's extreme sensitivity in early recovery means that even a pause episode can feel physically identical to the beginning of withdrawal. The brain's response is to seek the substance that reliably ended the physical alarm in the past. Understanding this distinction is critical. The craving anxiety is not evidence that you are in medical danger. It is the recovering GABA system oscillating through periods of lower output as it recalibrates. The tools below address both the psychological and physiological components. The GHB craving types and their interrupts. The GHB craving interrupt, 5-minute protocol. Identify the type. Anxiety-driven, physiological alarm. Sleep context, nocturnal waking. Social cue, environmental trigger. Anhedonia, flatness. The type determines the primary response. Execute 4-7-8 breathing. 4 full cycles, minimum. For anxiety-driven cravings, do 6 cycles. This is your primary non-pharmacological GABA system intervention. It is real and it works. Take your anxiety supplements. L-theanine 400 mg, magnesium glycinate if not already taken. These are not placebos, they are GABA-supporting compounds that address the neurochemical deficit underneath the craving. Change your physical environment. For social/cue cravings, exit the environment before doing anything else. For anxiety cravings, move to a different room, go outside, change your physical position. The environment is part of the circuit. Make contact. Text or call your support person, recovery contact, or 988 line. GHB cravings, especially the anxiety-driven type, lose much of their power in connection. The isolation that GHB's around-the-clock dosing schedule creates is part of the dependence architecture. Connection is its antidote. Execute your natural GABA activation. From Section 6, breathwork practice, cold water exposure, gentle movement, music at 60 to 70 BPM. You are activating the calming system through its natural inputs. Document. Trigger, type, intensity, 0 to 10, action, outcome. After 3 weeks this data will reveal your craving pattern with a precision no therapist session can match. Section 6, Porting the Addiction, Building Your Own GABA. Classical Building the Centurion, Centurion Paper C28 applied to GHB recovery, the internal off switch. GHB gave you something specific. It gave you a nervous system that would finally stop. Not partial relief, not reduced anxiety, complete quiet. The GABA-B activation that GHB produces at recreational doses creates a state of neurological stillness that the anxious, overstimulated nervous system experiences as profound relief. The Recovery Kernel's framework says, that state is not only accessible without GHB, it is more accessible, more sustainable, and more genuinely yours when built through the brain's own systems. What GHB was doing from the outside, the recovered GABA system can do from the inside. The question is what conditions trigger it. This is the natural addiction architecture for GHB recovery, not building intensity, the stimulant target, or endorphin warmth, the opioid target, or anandamide flow, the cannabis target, but building the internal capacity for genuine nervous system stillness. Your own GABA. On demand. Without a bottle. Natural GABA-B and GABAergic state activation. The Chemsex context, additional recovery architecture. Classical building the Centurion, when GHB was part of a larger chemical and sexual pattern. For those whose GHB use was embedded in Chemsex, the combination of GHB, crystal methamphetamine, and mephedrone in sexual contexts that characterizes a significant portion of GHB use disorder in LGBTQ+ communities, the recovery architecture requires additional elements beyond the core GABA restoration protocol. Sexual health, HIV testing and PrEP status assessment are medical priorities. The Compendium Specialist Protocol for HIV/STI Prevention in the Context of Substance Use, Volume 7, Protocol 35S Series, applies directly. The Centurion paper on Chemsex in the compendium addresses the HIV firewall architecture explicitly. Sexuality in recovery, the disinhibition that GHB and meth provided in sexual contexts was often managing genuine sexual anxiety, shame, or the difficulty of authentic vulnerability. Recovery requires building the capacity for sober sexual experience, which for many chemsex users requires specific therapeutic support, not just substance cessation. The social architecture, chemsex communities form tight social bonds organized around substance use. Recovery often requires building a parallel social world, sober LGBTQ+ community, recovery-oriented spaces, that is not in conflict with the sexual identity the chemsex community provided belonging for. MDMA/methadone recovery alongside GHB. In chemsex polysubstance use, methadone and MDMA components require separate attention. The serotonin system damage of these substances is addressed in the MDMA-specific sections of this guide series. Section 7, Navigating the Recovery Kernel, Your Protocol Map. Section 8, The Medical Support Layer. GHB use disorder is one of the most underserved areas in addiction medicine. Many emergency physicians, general practitioners, and even addiction specialists have limited experience with GHB withdrawal management and the specific pharmacological options most appropriate for it. The information below is intended to help you advocate for appropriate care. Baclofen, the most evidence-supported GHB withdrawal treatment. Baclofen is a GABA B agonist. It acts on the same receptor that GHB primarily activates. This makes it pharmacologically the most specific available treatment for GHB withdrawal. Key points to discuss with your physician. Doses required for GHB withdrawal management are often much higher than doses used for muscle spasticity. Baclofen's approved indication, up to 200-300 mg/day in divided doses. Standard spasticity doses, 10 to 30 mg, may be inadequate. Titration should be guided by withdrawal symptom severity. A validated tool called the CYR, alcohol, can be adapted, but ideally the CGWS, gamma-hydroxybutyrate withdrawal scale, is used if your facility is familiar with it. Baclofen taper following stabilization. Once withdrawal is controlled, the baclofen dose is gradually reduced. The taper should be slow, weeks to months depending on severity of dependence. If your emergency physician is unfamiliar with baclofen for GHB withdrawal, the clinical literature supporting this approach is available. Key papers include Adolorado et al., 2009, and Bell et al., 2011. Addiction medicine specialist consultation is appropriate. Medications for co-occurring conditions. Anxiety, post-detox buspirone, non-addictive serotonin 1A partial agonist, is appropriate for the persistent anxiety of GHB recovery without the dependence risk of benzodiazepines. Takes 2 to 4 weeks to achieve full effect. CYP3A4 metabolized. Depression, MTHFR variant depression responds to 5-MTHF before prescription intervention is necessary. Assess response to 5-MTHF for 4 to 8 weeks. SSRIs if clinically indicated, with CYP2D6/2C19 considerations for selection. Sleep, quetiapine, low dose, 25 to 50 mg, may support sleep architecture in severe GHB-related insomnia. Time-limited use. Not first line but appropriate when supplement stack is insufficient. Narcolepsy, sodium oxybate patients discontinuing sodium oxybate requires neurologist-guided management. Alternative narcolepsy treatments exist, modafinil, armodafinil, solriamfetol, pitolisant, and should be optimized before or concurrent with sodium oxybate reduction. A final word. Classical building the Centurion, the system that was outsourcing its stillness has everything it needs to find it again. GHB recovery is among the least publicly discussed and least clinically supported recovery journeys that exists. The people who need this guide are often invisible to the systems that would help them, too functional to seek standard treatment, too dependent to manage alone, too stigmatized in some contexts to disclose, and too often told that what they are experiencing is not that serious by people who do not understand the neurobiological reality of GABA B dependence. The recovery kernel was built for exactly this population, the ones who were failing standard treatment not because they lacked commitment but because the standard treatment was not addressing the specific biology of their specific situation. The biology of GHB recovery is clear. The GABA-B receptors upregulate. The glutamate system normalizes. The HPA axis restores. The dopamine system rebuilds. The sleep architecture recovers. The process takes longer than most people are told, and the path through it is narrower than most people are supported through. But the nervous system that found the stillness it needed in a bottle of GHB is the same nervous system that can find it in a breath, a cold river, a room full of people who understand, a creative practice that absorbs it completely, and a contemplative tradition that has been cultivating this exact internal state for thousands of years. It built the trap. It can build the door. Refer to the Recovery Kernel Complete Centurion Compendium for all referenced protocols. Crisis, call or text 988 Emergency, 911 SAMHSA, 1-800-662-4357. Warning: harm reduction resource, not medical advice. How to recover from GHB using the Recovery Kernel Substance Specific Navigation Series.